Hello, everyone. Chapter 2 is going to just kind of lay the foundation for the rest of the book. We're going to go over the most commonly used acronyms and just go more into the reimbursement process. Okay, so you have to look at healthcare as a business. Businesses survive by having income. So in healthcare, income is earned by providing services to patients, right? So in that case, the HIM department is not an income producing department. It doesn't provide any of the services that earn the hospital money. So it's considered a service department. It's still important and plays a role in the revenue cycle, right? But so what HIM does, they make sure all claims for services are accurate and complete. Once the charges are captured on the claims, the bills are dropped, meaning they move into the accounting department of the facility. At this point, the charges are put into accounts receivable, or AR. Accounts receivable is like all the money that is owed to the business that they haven't gotten yet. So when charges are posted, the AR will go up. When they receive the payment from the claim, AR will go down. In accounts receivable, revenue is recorded when it's earned. Okay, so after the service is done, but before they ever get the money. Cash is recorded when they receive the payment. Okay. A bill cannot be created until the coding is complete. So all of the diagnosis and procedural codes are done. When a patient is discharged, but the bill has not been completed, the patient would go into a report called Discharge Not Final Billed, or DNFB. Most facilities allow 3 days for bills to be finalized or dropped before they are considered DNFB. This is called the bill hold period. Okay, so you do need to know the difference between the bill hold period and the DNFB. There are a few reasons why a bill wouldn't be dropped in time. So if the coding isn't complete, obviously, but also sometimes the coding is done, but the code hasn't been linked to the charge on the CMS form, or the claim could be rejected during like a claim editing process because it's missing some data, or a revenue code was incorrect or something like that. Okay. Coders have to work with the physicians and query them if there's not enough documentation, or the coder can tell that a procedure was done for a certain reason, but the doctor didn't put that reason, or things like that. Also, clinical documentation integrity, or CDI specialists, which are nurses that review medical records to make sure everything was documented properly. The billing department will also check the bills for missing or inaccurate links to try to cut out as many DNFBs as possible. Organizations will also be looking at accounts receivable days, which is just the average number of days between discharge date and receiving the payment. So how long is the claim sitting in accounts receivable? Okay, so this will show them if their revenue cycle is successful or not. All right, now if you remember, we can have commercial insurance or federal or government insurance. The government insurance programs are Medicare for people 65 years and older, or people that are under 65 that have disabilities. And then it also covers any age person that has end-stage renal disease. There are 4 parts. You may want to take notes on this. There are 4 parts, and you can choose which parts you want. So Part A covers hospital services. Part B is outpatient services, durable medical equipment like wheelchairs and stuff. Part C is considered advantage plans, things like eye and dental care, or specialty services. And then Part D is for prescriptions. Members have to pay a monthly premium for Parts B and C only. Part D, they have to pay their deductibles and their copays, and you don't have any of that with Part A. So you can think of B, C, and D as kind of like add-ons. Oh, I don't know why I switched. So Medicaid is for low-income adults, for children, pregnant women, elderly adults, and people with disabilities. So this is funded by state and federal taxes, but each state has its own eligibility requirements. CHIP, or Children's Health Insurance Program, is for uninsured children in families that make too much money to qualify for Medicaid, but not enough money to afford private insurance. TRICARE is for active or retired military members and their families, or the families of military members that have been killed. CHAMP VA is the Civilian Health and Medical Program of the Department of Veterans Affairs. This is for veterans that are not eligible for TRICARE, or the spouse and kids of a veteran that was disabled from something service-related. Indian Health Services provides medical and public health services for federally recognized Native American nations, and also Alaska Natives. And then Workers' Compensation provides medical benefits to people that have a work-related injury or illness. There are 4 programs in workers' comp, but you don't need to know each of these. Okay, then we have the commercial insurance plans that we've already kind of talked about: Humana, Blue Cross, Aetna, among many others. Let's see. These can be individual or group plans. The policyholder gets to look at all of the options and pick the ones that best fit their needs. Most of these are managed care plans, where the employer is negotiating for different plan options with the managed care organizations. Okay, the next several slides will talk about different reimbursement methods that are used. We should all remember what fee-for-service reimbursement is. That's where the doctor is paid after the services are provided and billed. It's also called indemnity health insurance. Okay. The problem with fee-for-service reimbursement is that it incentivizes quantity, because the doctor only gets paid per patient or service. So they want to try to get as many people in and out as possible, as opposed to value-based payment systems where they're paid based on quality outcomes and such. Most payments used for fee-for-service based, most payments used to be fee-for-service based, but there has been a shift to where now over half are actually value-based, which again is great for us as patients, right? They're focusing more on quality. Okay, in the U.S., most health insurance is provided through MCOs now. The goal is to try to balance managing costs for the doctors while still providing quality care to patients. And again, this is where the provider negotiates with the MCO a rate of pay per patient, that they get on a monthly or annual basis. So healthier patients earn them more money. Less healthy patients could cost them money. This is that capitation payment method that we talked about already. With this method, there is a fee schedule that lists out every service that's covered and the amount the insurance company will pay for each. So this fee schedule is negotiated as well. The doctors can kind of, try to fight for higher payments on certain things, etc. Okay, the Preferred Provider Organization, or PPO, is the most common MCO. With PPOs, there's a large network of covered doctors and hospitals, so like a lot of options that are considered in-network. So the patient pays a lot less for seeing one of those than someone that is out of network. It can get very expensive if they're not in network. A health maintenance organization, or HMO, is kind of the opposite. There's a much smaller selection of in-network doctors to choose from, but the patient's monthly premiums are usually a good bit lower than in a PPO. Patients are also required to have a primary care provider or PCP in an HMO who, if you remember, are the gatekeepers and kind of coordinate all of their care and referrals to specialists or any of their admissions. HMOs also place more emphasis on preventative care than PPOs, which is a good thing, right? They want you to not get sick in the first place. And then point of service or POS plans is kind of a combination of the two. It's a smaller network to choose from, but costs are low, and patients have to have a PCP in this one as well. Okay, CMS uses a prospective payment system, or PPS, for Medicare. These payments are based on a predetermined fixed amount. These amounts are based on the classification systems for each service. We're going to go into more detail on this in a few chapters. The Medicare physician fee schedule is used to pay doctors' services that are covered by Medicare Part B. So these are also predetermined rates for each service, and CMS will look at it each year to see if the rates need to be changed. Okay, so there are standards known as relative value units, or RVUs. These are payment components that measure the value of a service compared to other services. Okay, so here's what they're looking at. The physician's work. How much time and how intensive was the service? How skilled is the doctor? How much effort did they have to use to do this service? They're looking at the practice expense. How much does the practice, the doctor's office, or the facility cost to provide the service? And this includes rent, utilities, equipment, the salaries of the employees, okay? And then they're also looking at malpractice expense. What is the cost of liability insurance? All right, so each of those three things is assigned a value on a scale. Every year, CMS sets these numbers for each service. So, for example, a swab to test for the flu is going to be very low intensive, low cost service compared to doing a chest x-ray, right? So the RVU for the flu swab will be lower than the x-ray. Okay, so then they take the RVU number for each of those three things, the physician's work, practice expense, and malpractice expense. And then they put them in a formula with a geographic adjustment factor, or GAF. This just basically takes cost of living into consideration, which is different in every state. So, the cost of living in California is much higher than the cost of living here in Louisiana. So everything here is going to be cheaper to do. The GAF kind of factors that in. Okay, so then the formula will create this payment amount. That is what the doctor receives. So this big formula gives us the fixed rate for that year. And they redo this big formula each year to give us these fixed rates that they will provide for each service. I hope that made sense. Okay, doctors that enter into an agreement with CMS to accept Medicare patients are called PARs, or participating providers. They receive direct payment, so they'll get paid a little bit quicker. And Medicare will pay 80% of whatever the allowable charge on the fee schedule is, and the patient's responsibility or coinsurance is 20%. Doctors don't have to accept Medicare patients, though. I think I said it in one of the other presentations that typically they receive a lot less money, or not a lot less, but less money for services on Medicare patients than doing that exact same service on a privately insured patient. So some choose to be non-PAR or non-participating providers. They can accept Medicare patients on a claim-by-claim basis, but there are restrictions, such as the amount they can bill to the patient, known as the limiting charge. This is a 5% reduction of the allowable charge. They calculate that number by multiplying the allowable charge by 115%. I know that seems confusing, but that's just how it is. Okay, the Affordable Care Act that we talked about already initiated the formation of Accountable Care Organizations, or ACOs, with the goal to improve quality care while lowering costs in the hopes that everyone has access to affordable care. Okay, the goal, like I said, improve care, quality care while lowering costs. This is not a health insurance plan, though. It's a network of doctors and hospitals and other staff to just coordinate patients' care. There are 3 characteristics of an ACO: managing patients across the continuum of care, planning budgets and resource needs ahead of time, and being big enough to support comprehensive, valid, and reliable measurements of performance. Okay, so what is an ACO? Anyone without health insurance can qualify for coverage by an ACO. Some ACOs have primarily Medicare and Medicaid patients. Some may be, people that are homeless or just people that don't have any type of insurance. The patient doesn't sign up for this. They have to ask their doctor if they're a member of an ACO. Okay, so if a patient receives most of their care from a doctor that is in an ACO, then the patient is considered to be in the ACO. Okay. We've already talked about these methods of cost containment, so I'm just going to review very quickly. Pre-admission review, also known as prior authorization or pre-certification, is required by some health insurance plans. Before a patient is admitted for a non-emergency procedure or service, they basically have to ask permission from the health plan. Like, if I have this done, will you cover it? And so the plan is checking for medical necessity, basically. Utilization review is looking for that medical necessity before a patient is admitted. So pre-admission, they're looking at it the entire time they're in the hospital, which is called concurrent. And then after discharge, so retrospectively, their records are being checked every day to make sure they're getting the right level of care, that they're not using supplies they don't need, and that they don't stay admitted for longer than needed. And the last one is very similar, but case management is a group of people, usually social workers, but working with nurses and doctors to plan out and make sure resources are being used properly. The focus for case management is improving quality of care, but also reducing costs. All right. Let's see. So here are some of the different technology or tools that are used. Before the 1980s, coders would use coding books like this, okay, this humongous book, to assign diagnosis and procedure codes. So as you can imagine, this took a lot of time. Like, if you've never looked at, it's a lot of tiny words and codes in there just to do one record. So this became so much easier and quicker once they created encoder software. It's basically like an electronic code book, and it uses an algorithm that mimics a tree to really help the coder. So if you input a certain medical term, it will give you the branches, okay, or the different options to select next until you eventually get to the final code. So encoders are really great, but you can't just rely on it alone. You have to still be able to use the code book, or else the encoder could lead you to the wrong conclusion, okay, the wrong code. Especially if the coder doesn't feel confident in what the encoder says, then they'll use the code book. They're going to still have their code book right next to them to verify everything. So the encoder is important for coders, but they have to really have really good knowledge in pathophysiology, medical procedures, medical terminology, to be able to read a record and understand what's happening. Computer-assisted coding, or CAC, is incorporating artificial intelligence into coding. This would never replace human coders because there's always going to be a need for human logic and intelligent decision making in coding. AI is great, but it can only do so much. And sometimes the answers it gives are not logical. For example, I think there are several people in one of my other classes who have been using Chat GPT or some other AI software to answer their questions. And just know that we can tell when you do this because sometimes it doesn't always make sense what the question asked was. Anyway, so CAC doesn't make like meaningful decisions about what's in the health record. It just suggests codes. CACs use natural language processing or NLP to read the electronic health record and pull out like keywords and phrases in order to predict what codes should be used. It uses like all kinds of algorithms and like statistical analysis to do this. And you can kind of think of it like how spell check works in Microsoft Word. Okay. Oh, we're not on the next one yet. All right. Most CAC tools are based on either a logic-based or a knowledge-based software. Logic software is based on rules. So if there's a procedure code that can only be used if there's this one specific diagnosis code, the logic-based software is going to use that rule to find the match, find the right code. Knowledge software uses keyword search tools, which isn't always going to be great because what if the phrase that the doctor uses isn't the typical way it's stated, right? So there's a lot of room for error. This tool will only search for those specific phrases, so it would miss it, okay? Third type of CAC software that's been developed is called Artificial Intelligence Deep Learning System. This acts as a coding assistant to the medical coder. So these types of systems can learn and adapt. The program is given like a sample of notes, like doctor's progress notes, and then given the correct codes. And it'll start to look at patterns and come to conclusions about it. So the codes aren't based on rules like logic-based software. It's not based on keywords like knowledge-based software. The system is like understanding what it's reading for lack of a better term, which is kind of crazy. Okay, last slide. What are the benefits and features of CAC applications? ICD-10 CM was implemented in 2015, and it was a big change from ICD-9. But because we had these applications, coders actually started to learn ICD-10 more quickly because they were continuously going back and forth verifying the codes. CACs can look at accuracy, or, actually we can look at accuracy now by comparing the way coding was done before versus what could have been done using a CAC application because they have increased efficiency, which was easy to figure out just based on how much time is spent coding each record now than it was before. And then return on investment can be achieved because now that coders are getting through their workload more efficiently, they're not having to outsource or pay an outside company to do, the backlogged records they would pile up that need to be done. Okay? All right, that's all I have for you today. Have a great week.